Good, Mark Sakel, talk to you in my role as Chief Medical Officer of Meritage Medical Network. I'm a practicing internist and geriatrician in Nevada, and I'd like to spend about 32 minutes on risk adjustment programs. Those are programs where we take some financial risk for taking care of patients, and the amount that we receive is based upon how properly and intensively we code for care that we provide. So first, some definitions you probably did not learn in residency or in early practice. First we use a lot is RAF, which is risk adjustment factor. That is an estimate of a patient's or population's complexity and expected cost to the payer. So what Medicare does is look at diagnoses, follows patients for many years, and then find out how much they cost. And then there's a hierarchy of payment for each of those patients. It's that some diagnoses don't count, such as low back pain or coronary artery disease. The other diagnoses do, such as atrial fibrillation or stroke. So most of it becomes intuitive as you use it, but those are the diagnoses that count. And those diagnoses that make up the RAF are called HCC codes, hierarchical condition categories. This reflects point value ascribed to each of the diagnoses. They are added up and then adjusted, and then you get your RAF for the patient and then your population. Properly, what does properly mean? Properly means that every single year you diagnose the same active diagnosis, and you also indicate the status of the problem and your plan. I'll talk about this later. So if someone's had an amputation in 2017, you documented amputation, wound clean, continued dressings, and you do the same thing in 2018. The next step is payer calculation. Calculation takes the RAF that we have put together from the HCC codes that we document, add a demographic factor, adjust the averages to a 1.0, and gives us a score. Finally, payment is substantially based on the RAF score for the population we care for. And we're talking about two populations here. One is the Medicare program, which is SCAN, and the other is the risk commercial program, which is WHA. All right. So I've stated this graph a long time. This is from the New England Journal about 6 months ago. If you look at the solid line that let's the dotted line first. The dotted line shows pre and post RAF scores for individual patients. And in the dotted line, the adjusted and unadjusted risk scores are the same. That's ideal. That's if everybody documented with equal intensity. The line represents how actual physicians in various counties document for the same diagnoses. So you'll see in St. Paul, for example, we're way above the dashed line. St. Paul docs get a lot more money for the same diagnosis because they code properly. If you're at McAllen, Texas, on the upper right, you'll see that it's way below the dashed line. For the same diagnosis, they will get 20% less than the line and probably 30% less than the St. Paul docs. So to do things well, and it turns out, if you look at the dark blue or teal in the Rust Belt and other areas, that most doctors who live in areas that vote for Trump make more money on these risk products. If you're in California, you'll see we're some form of purple, which means that we document less than expected. So that compared to a doc in Minnesota, we are probably getting 30% less reimbursement for the same care that we provide. Okay, is RAF important? And certainly there's the issue of payment for services rendered, but it also levels the playing field between the patients that we see here in California, in West County, and ones in Minnesota. If both document the same level, Medicare will pay us the same, recognize us the same, give us the same service. Patients that have high RAF might be individuals that will benefit from case management. And in any kind of quantitative analysis, you can basically normalize patient groups if you're doing an intervention. And we see a dude examining a very sick patient and will then appropriately document the RAF score in his documentation. So here at Charge, we have about 5,000 scan patients. Before in December 2015, our score was 0.69. We lost $2.5 million on the scan product. That is not sustainable. Then we started these programs, of which this WebEx is a part, and we pretty much broke even in 2016 as physicians started documenting and coding appropriate diagnoses. In 2018, we've done even better, and we probably will make some money on this product. I don't think it'll be $2.5 million, but it'll be definitely in the positive range. I hope to hit 1.0, which is the Medicare average across the country in this calendar year. And this will enable us to continue serving the patients, and we take the profits that we make and we turn about 80% of it back to physicians in incentive bonuses. So I have to read all the words, but there's two important points. One is if you've documented someone's AC code, such as stroke with hemiparesis in 2017, in January 2018, Medicare thinks they are no longer hemiparetic unless you document again. So if you're a cylinder, what we do is taking that documented risk, which is the dark blue, and with code that you already provide care for to reach up to the actual risk. So that's our risk gap or risk loss. So the goal is to make you skillful enough and give you the support that we can actually document at the level of patient complexity. Here's an example. This is Esther, and it takes me, I love looking at this picture every time, and you can imagine why. And look at her RAF score. If you're on the bottom, where you see demographic risk factor of 0.815, just for breathing, that will give us a RAF of 0.815. However, if physician, this largely falls to us primary care docs, document systolic heart failure, major depression, quadriplegia due to severe RA, her HCC risk factor will be 1.5, bringing her to a total of about 0.3 after some normalization. What does it mean in real terms? A RAF of 2.3 will bring the plan or medical group $10,000 every year just for documenting. If suggested the demographic risk factor, that would be closer to maybe $1,000 a year. So it has a lot to do with basically supporting the care of these patients. Switch gears now for a moment to documentation. And we all have our ways of doing it. We all learn SOAP notes. Other people do problem-based notes. But here's how Medicare auditors want us to do it from now on. As you know, whatever Medicare does, the commercial plans do as well. So no matter what you do, I would encourage you to document this way in the future to make yourself audit-proof. So there's basically three components. The first one is the diagnosis. Diagnosis is the ICD-10 code you're going to use or chronic atrial fibrillation. There's two choices. If it's a stable problem or if it's a chronic problem, previously diagnosed, you have to add in the status of the problem. Atrial fibrillation, stable. That's what you have to do. Or atrial fibrillation, way too fast. And to come up with a plan. Plan, increased beta blocker. All it is, it's very brief. The possibility is that you just made the diagnosis in the office and you logic. Atrial fibrillation, logic, noted EKG with controlled rate, plan, continue beta blocker or cardiology referral. So that's basically the most important slide on how you document, and we'll give you some examples of this. Okay, 3 components to appropriate diagnosis. First, diagnosis, and we'll help you identify these that are high-value codes. In other words, you have to look for them. You won't have to study. You won't need cheats. We will, and we have actually done this already for all your scan patients. We have a list of diagnoses that we think are accurate, and I'll go over this again in the future. Then why or how you came to the diagnosis, if it's a new diagnosis, and then what we're going to do about it. So here's an example of a diagnosis I never made until 3 years ago, abdominal aortic atherosclerosis. It's about that Medicare believes that patients who have this documented are costly and more complicated, and that makes some sense. And if we don't document it, they're not going to pay us for it. And they pay us about, I think, a RAF of 0.18, which is maybe $7 a year. So, how to diagnosis? Seen on ultrasound or seen on X-ray of the back. Your plan recommend aspirin. That's what you need to do. What if it's an existing diagnosis? The diagnosis, and what we'll do in some cases is you might have a diagnosis of depression, which is not a high-value HCC code, but if in somebody Zoloft or Celexa, actually the proper diagnosis is major, minor, major, moderate depression. And then you give a evaluation statement. How's the patient doing? That's the status. And then what you're going to do about it. So the year 2017, I diagnosed abdominal aortic stenosis, seen on ultrasound, aspirin recommended. This year, I'm going to abdominal aortic atherosclerosis, stable clinically, will monitor. And that's very common verbiage that I use. And again, Corey will help you identify the codes, and you'll have them at the time of the visit. Here's some documentation examples that are a little bit more extensive. I got these from one of our pulmonologists. First one is J44.9, asthma COPD overlap syndrome. For your information, asthma is not an HCC code for Medicare. It is for the commercial plans. But asthma COPD overlap syndrome is. That's when you have fixed obstruction as well as reversible component. And he rank exam is normal. PFT suggests moderate asthma with both a fixed and reversible defect. Then you go down to his plan, which is linked to number 1. Delirium daily, rinse your mouth, use albuterol for symptoms, blah, blah, blah. Then anything with cough, postnasal drip. This is a new problem in his documentation. He tells you why he thinks it's the case. That's his logic. And his plan is use regimen for HOS and postnasal drip. Okay, so basically, you have to imagine that a hostile reviewer who used to work for the FBI but lost his job is reviewing charts, and to make sense to that person that you've done the diagnosis, you've done the status, and you've done the plan. So it'll be good because you can figure it out. A little bit better if he put everything together for each diagnosis, and this is how I do it. Diagnosis, I give my logic, and then I give my plan. And then I go next problem. I go from asthma to cough to dysphonia to postnasal drip. That way, no doubt that a reviewer will say, okay, he's got status, he's got logic, he's got plan. Your assessments, a little pithier. Metastatic breast cancer to the liver. This is a previous diagnosis, worsening disease to the oncologist. All you do. Metastatic breast cancer to liver. If it's a new diagnosis, you tell them how we made the diagnosis. We saw it on CT. Plan to see the oncologist. Senile purpura. Never diagnosed this until 2016, maybe 2015. But that people with senile purpura, according to Medicare, do have more complications and cost more over the years. They may take this one in the future, but it's really for now. Noted on examination due to age, actinic damage, and aspirin, patient reassured. Whatever it is, you document that, and Medicare will recognize this. Other common one that you haven't been using probably is the diagnosis of secondary hypercoagulable state. If someone is persistently in fibrillation, not paroxysmal, they have a secondary hypercoagulable hypercoagulable state. It must be that the paroxysmal AFibs don't cost as much as the persistent AFibs. So we make diagnosis of secondary hypercoagulable state. Clearly, that region is in the atrium. And you put your plan, continue Coumadin, continue Xarelto. And those are something that we'll point you to. More quick examples: atrial fibrillation, rate stable, no bleeding or TIAs, continue the strategy of rate control and anticoagulation. I use that one every day in practice. And then I add secondary hypercoagulable state once a year, and we will point you to this. C4, you have to sort of remember, and we'll help you with this. You diagnose a CKD4 if your EGFR is less than 30 twice, not just once. This is okay too. And with an established diagnosis, you might write worsening serum creatinine, stop NSAIDs and recheck, get ultrasound. And the fifth way to do this, and this is acceptable, is to write stable, continue current management. You do that for all problems if that's really true. This is a gold mine of HCC codes. So stone codes might not be HCC unless they're associated with diabetes. So diabetes with renal disease, with almost any eye disease, cataracts is one, neuropathy, peripheral vascular disease, with dyslipidemia. Dyslipidemia alone is not an HCC code, but in the setting of diabetes, dyslipidemia associated with diabetes is an HCC code. I'll find that for you. Erectile dysfunction is similar. If you have erectile dysfunction and have diabetes, apparently you're not more cost of Medicare, but if you have both, it's an HCC code. Okay, slide. So here's some examples of this. Diabetes with cataract, you might write this on your pre-op note. Cataract alone is not an HCC code, but if it's associated with diabetes, it is. So I diagnose type 2 diabetes mellitus with cataract on my pre-op, and worsening vision, follow up with Dr. I. Diabetes with hyperlipidemia, assess plans, LDL suboptimal, increased Lipitor, diabetes, erectile dysfunction, no improvement by Cialis. Again, erectile function, hyperlipidemia, and cataract in non-diabetics are not HCC codes. So I'm easier, and I'm not sure what kind of electronic record you have, or if you all have electronic records, is to have diabetes as a diagnosis alone, because that's the one you'll use for subsequent visits, and then have the complications below, sometime during the year. I'm sure you have a lot of patients are depressed. You see that the HCC code on the right is 0.33, which makes no sense. That's a fairly high HCC code, and that would be about $1,300 a year for having somebody depressed. With the definition of depression, some of what are clinical judgment, but certainly anybody on medications for depression or has a depressed PHQ-9 scale, which I encourage you to use, is depressed. And these are some of the codes that are have the specificity that Medicare is now required. And just remember, if someone is on loft or you do a PHQ-9, I don't write depression anymore. I write major, mild depression, major, moderate depression, intermission, and I don't have many psychotic patients. You guys might have more. Alcohol drug dependency is an HCC code, even better than depression. And recall, of course, that once an alcoholic, always alcoholic. So 1 year, my addicts in recovery diagnose alcohol dependence in remission, and we'll collect the HCC points. And it's other drug issues like drug dependence, uncomplicated, document that once a year as well. So these codes that you would not think necessarily of as being high value or they're somewhat idiosyncratic diagnoses, and I'll go over them quickly. I've mentioned a lot of them. Senile purpura, we want to diagnose once a year if it's present. Secondary coagulable state for our patients with chronic atrial fibrillation. And an HCC code and high angina. Either the patient has angina or you're driving nitroglycerin in the expectation that the patient might have angina in the future. A common issue that's missed is the primary cancer with metastatic sites separately coded. So with breast cancer metastatic to bone gets two diagnoses, one breast cancer and the other metastatic cancer to bone. Metastatic diagnosis is a much higher HCC code. It's not a diagnosis in primary care that we often make unless someone comes to your office with compatible symptoms, but we do see late effects of stroke, and late effects count, and the most common one is hemiparesis. So my diagnosis is late effect of stroke, hemiparesis, event is, status is stable, and PT pressure. Now, colostomy or an amputation once a year, document the status of colostomy or amputation. Clean, continue dressings once a year. If you don't, Medicare thinks the amputated toe has grown back. Paresis due to Parkinson's, multiple sclerosis, and advanced dementia. Paresis means, or functional paresis means that the patient needs a lot of help getting up or is wheelchair bound. That's a diagnosis to consider in folks who have these disorders. Atherosclerosis on ultrasound reports, that's on a goal line. Pulmonary hypertension, which is defined as a PA pressure of 40, or the cardiologist says so. Secondary pulmonary hypertension due to heart disease, edema stable, plan continue Lasix. Major depression, we've talked about PHQ-9 over 5, although most of us are about 5, probably listening to this WebEx, or on nation. Sarcopenia I never knew, but apparently is less than 150,000 platelets on 2 occasions. Carotid disease, but not stenosis or atherosclerosis, is also a diagnosis. So I'll use carotid artery disease if someone has atherosclerosis. A little sneaky, but I do it. Okay, so it's actually an important thing to keep in mind. So you have 276 scan numbers, which is a piece of change. Dr. Zelk and Dr. Bowen are the winners. So we have pulled all your charts. Our coding specialists have looked at them and put together what they think are appropriate diagnosis codes for you. All right. How can we succeed at this and not torture you too much? It is important that the RAF at the end of the year determines what montage gets paid for the care of these risk patients and allows us to continue paying for them in the future. So we have programs to help with this. One is the risk adjustment program that I've alluded to previously, and the other is we can send our mid-level nurses to the patient's home and do it for you, and you don't have to stress about it at all. Scan members, that's their risk product. Our coding specialists have pre-reviewed all your patients and identified potential HCC codes. You'll get the pre-review from Dr. Cunningham, and these pre-reviews, if for some reason you don't have it, you can have your assistant look them up on MIPANET, and then you do these diagnoses and you decide whether they're appropriate. If they are, write stable continued current management, or whatever you want to write, as long as it satisfies the documentation guidelines. I'll come back every one or so and see what you did. If you hit 80% of the codes, Meritage will pay the organization $100 per patient. Once we pay it out quarterly when we're on time. Okay, what you'll get, and it looks a little confusing, you get the name of the person, obviously. You'll get the PA or NP who went out to the patient's house or did a review, and you'll get potential diagnoses. So, diagnosis here, diabetes mellitus, and the source of that would be a diagnostic report we got from scan. That means we found it from claims, I guess. And the review committee assess and document most levels of specificity. The next potential code is alcohol dependence, uncomplicated. Review comments to you if the patient's still drinking, change the to alcohol in remission. And it's that she got this source from an HPI that probably you wrote the year prior. Functional quadriplegia. Now, this is one that may not apply. The court has noticed that someone has kind of advanced RA or multiple sclerosis, and she asks, is the patient immobile due to their disability? And you either say yes or no. You're the boss, you're the doctor, and if it is the case, you code it, please. Finally, we will suggest to you senile purpura, which is non-thrombocytopenic purpura, and we'll suggest that diagnosis to you as a possibility for anybody who's over 70 on aspirin. All right, we come back, and this is the post-review, and this is what we base, the incentive payment on, the $100 that we give, and the diagnosis we'll see if you made the diagnosis. If you think and you have the energy to say, hey, this diagnosis doesn't apply, will we move it from the denominator? Some of our PCPs are very about making sure that this is correct. So if someone doesn't have functional quadriplegia, they just have multiple sclerosis, just tell us, no, they don't have this. All right, WHA members is fairly similar. We don't do every WHA patient since this is a commercial younger patient population. We just preview the patients we think might have high-value codes. You previews again from the good Dr. Cunningham, and these previews could also be found on MIPANET. And again, you'll get that. Hopefully, it'll be at your desk when you see the patient, and the ICD-10 codes if you think appropriate. So we're not going to review these patients. They're simpler. We're going to trust that you're going to do it correctly, and we'll also pay $100 for any face-to-face visit once per year. The easiest way to do this, and we definitely encourage you to do this, is to let our advanced practice clinician go out to the patient's home and do this in their home. And we'll call the patients, we'll say, can we come over to your house, can we do a health assessment? And this is fine to do for anybody who doesn't feel like doing these documentation, for patients who are homebound, and for physicians who just think this is all BS. What I'd like you to do is let us know that that's okay with you so we can generate a letter from you to your patients. Our mid-levels will go up there, they'll write a note, they'll send it back to you for scanning in your record, and we will capture the codes just with our own mid-level folks. Okay, so finally, close to finally. All right, so the thing is for our RAF for WHA patients is 20% lower than other plans. Now, we may healthier folks. That tells me that we are really losing out on lots of codes for care we already provide. For WHA, we'll encourage you to see about the top 20% of those patients who we think are high risk. For scans, they're everybody high risk, and you'll get the Patel HCC codes, again, on MIPANET or hopefully on paper for your chief here. Document appropriately at any visit, doesn't have to be an annual wellness visit, and bonus the organization $100 per patient for any chart so properly completed. All right, so this is hard to do without a dialectic, but here's a case study. This woman's name is Zelda. She's 82. She has better RA. Doesn't look that bad if you look at her hands, but let's assume that's the case. She's brown. She has correct fibrillation and her PHQ-9 is 10. Medications, metoprolol, Xarelto, sertraline, and methotrexate. So think for a moment, if you can, what high-value HCC codes she has. She's wheeled down, she has RA, she's in fibrillation, she has PHQ-9, she's on methotrexate. Okay, so she's chronic fibrillation, that's 0.295. She has fibrillation, and therefore she has secondary hypercoagulable state. We know she's off with a high FHQC, so that's major depressive disorder. I'm assuming moderate, giving it a 10. You might not think of on your own, if you're by yourself, as functional quadriplegia, and that's because she's wheelchair bound. And look how that's worth 4 times as much as atrial fibrillation. CAL is one that you wouldn't have documented in the past. Rheumatoid, you probably would have figured out. And finally, she had a beta blocker and has a pacemaker. She likely has sick sinus syndrome. So that was the lowest diagnosis. We might miss that one without the cardiology notes. So normalized RAF is almost 3. And that every year, just for taking care of this patient, we will get paid $10,000. And if you don't do that, we'll get paid about $2,000 or $3,000. So with this, one, we're providing the care, we're just not getting financially recognized. If we are financially recognized, we continue to care for these patients, and we're going to continue to care for these patients. You, at some point in the future, will be audited by insurance companies or the feds, and they'd like to see that you document the way I explained. RAF for individual patients is an alert for us here at Meritage and maybe your organization, which might need outreach. So a RAF for us of over, 1.8 identifies a patient that our case managers contact. When you chart these ways, you often find things you did not previously suspect, at least I found that experience. And it's also a way to potentially reward primary care providers and pediatricians who are doing this documentation. So on spring chicken, I learned this at age 62. It was difficult, but not all that difficult. High above the hushed crowd, Rex tried to remain focused. Still, he couldn't shake one neck. He thought he was an old dog and this was a new trick. I invite you to greet this with an open mind. It's no worse than anything else we've been subjected to over the past 10 or 12 years in documentation. And I hope you will do your best, and we'll try to support you in any way we can. Thank you very much. This is Mark Sokell.